We are waiting for one more board member so that we can have a quorum.
No problem.
Yeah.
I just sent her another email, so
I did
hopefully.
too.
Oh, you did as well?
Yep.
Okay.
I don't think I have her number.
Okay. So I need to get you two connected with the tribe.
Okay, let's go ahead and do it. I'm going to go ahead and call this meeting to order. Let's go ahead and start with introductions. I can only see part of the room. Let's begin with Commissioner Trask.
Sharon Trask, Mason County Commissioner, District 3.
Melissa Casey, Community Health Manager, Mason County Public Health and Human Services.
Darren Moody, Hospital Commissioner.
Dave Wyndham, Director of Mason County Public Health and Human Services.
Christina Muller-Shin, Behavioral Health Team, Mason County Public Health and Human Services.
So if I understand correctly, we are still one shy for a quorum, so we cannot do the next one, which is an action, which is approval of the agenda. So we're going to go ahead and just move right into the program, right?
Commissioner Netherland, do you want to introduce who's on the screen?
Yeah, my apologies. Commissioner Van Busker?
Yeah, I'm from Hospital District 2.
And Christina already introduced herself, didn't she?
Yep, and I'll do a bigger introduction probably in a moment.
Okay. So with that being said, we're going to skip item number 2. We're going to move on to item number 3, which is the program. Who wants to lead us off? Christina, go ahead and hit it.
I'll start with the purpose of the meeting. So we've been looking at how to improve our outreach program and looking at different ways of tackling this. So our team we've met multiple times and came up with a new plan. So I'm going to turn it over to Melissa and Christina to walk us through the plan.
I'm going to sit over here just so I can be on screen if you don't mind me scooching in next to you, Sharon.
I don't. You can sit right here too if you wanted.
I don't know if that's a good...
I'm still on camera over there.
Yeah, okay.
Just really quickly before Christina goes into the presentation, so as Dave mentioned, we've had a lot of meetings. This is kind of stemming from additional funding that we got from the Department of Health to expand our current mobile program, add clinical services such as STI, HIV, Hep C testing and treatment, as well as the opportunity to kind of look at data from the past few years of doing, I think the past 5 years of doing syringe service programs out of our mobile unit and looking at what would be a better way to actually fill gaps and meet people where they are. Weren't quite seeing a lot of people the last couple of years of modalities have changed a little bit. I think in addition to there being transportation issues as well as mobility challenges, reaching a lot less people. So in the process of developing a home service proposal, which is what Christina is going to present today, we did meet with County Prosecutor, Deputy Prosecutor Tim Whitehead, as well as risk management to make sure that all the things that we were doing are within the scope of our work, are covered under the risk pool in terms of insurance, and defensible in court should anything come up with any of the work that we're doing. So I'm going to go ahead and turn it over to you.
Awesome, thank you so much. So first I wanted to thank everybody for coming to this very short notice meeting to talk about this. I know we didn't give very much notice, but we're hoping to move things along and improve our services. So as Melissa mentioned, said as I introduced myself as in the beginning, but I've been with public health coming up on 7 years. And we've been running this program for quite a long time. And so we're really utilizing the things that we've learned from our partners who are seeing kind of an increased success in engaging with this population. And I will move forward. So just to really brief what we're going to talk about today, I'll go over a real quick background of the program as it is, and you can see, well, the proposal justification. We'll really spend the majority of this time, I believe, talking about safety considerations. I know that this is one of the biggest concerns of the folks that we've talked to so far, so that's really kind of going to be the bulk, I imagine, of what we'll talk about. And then at the end, we welcome discussion, so there'll be, a time for us to elicit feedback before we go ahead and move on with the next steps. But we'll tell you what our anticipated next steps would be. So with that, we will continue. So a little bit of background, our substance use mobile outreach program began in November of 2018. So I put on the side, and I also included it in everybody's packet, just the 5-year report. We actually briefed the Board of Health on this earlier this year, but I changed the numbers to be a little bit more accurate. So to date, since the program inception, we have now served 849 unique individuals. That is 241 unique folks served in the year of 2023. So we have some demographics and site usage and referral information that I sent in that packet. But one of the things that I wanted to highlight is over the years we've noticed our participation kind of changing and becoming, I guess, reduced. And this is something that a lot of the programs around the state are also seeing with the change in substances available and kind of behaviors around that. And we also know that Mason County is unique compared to maybe some of the more urban programs in that we're incredibly rural. And a lot of our folks are, living, pretty far out, or just don't have transportation in general. So this program is particularly the target population that we're working with is folks who are in active use or people with behavioral health challenges. And we have a robust program that connect people to services. We ask every single person if at every single encounter, do you want referrals for treatment, medical, and dental? We have partnerships with a lot of our case management programs, treatment programs, so we can really streamline people into that care and also provide a place for recovery supports for some of our folks who are not using anymore. So one of the things when we were noticing that people just kept saying, I have a hard time getting here, and we know that the amount of people that would be interested in this program are much more than what we're actually serving. So we do ask at each person, how many people are you getting supplies for? Are you picking up for? And on average, there's around 3 other individuals that people are getting supplies for. But our program is not a transactional program. We've made this very, kind of one of the cornerstones from the beginning that we're not just distributing stuff and supplies. The engagement piece, the trust building piece, and that direct connection to services, to treatment, medical, dental, recovery support services is one of the biggest things, and also just providing that opportunity to build that relationship, which, there's, again, I think on the other side of this 5-year report, we have some testimonials from our participants of what this program has meant to them and how it has helped them. So we asked, so we don't want that, we want to reduce the number of people that they were getting stuff for, so we're having more face-to-face connections with people, and we can actually offer that direct care, that relationship. And then with the expansion of our syndemic clinical services, we also really want to increase the folks who are able to access those services. So we started a survey, and we've done a lot of work, I guess, over the past year on this before, putting this proposal together. One of the things we did was survey our participants. So we did a couple month survey. So out of 43 people that we surveyed of our active participants, 79% said the people they know who would like to utilize harm reduction services had difficulty getting to our sites as they currently are. And all of them cited transportation and or mobility issues as that reason. And I'd also like to just kind of point out that of the participants who do regularly engage in our services, over half of those also reported having a difficulty getting to us. And again, transportation was that main reason. Currently we call them like fixed mobile sites. We operate out of an RV, and we go to Belfair in partnership with the community food pantry. So we park in their parking lot during their hours, some of our participants are able to get food and other resources from them. We park at the, no longer as of today, we park on the Skokomish Reservation at this empty lot that they've had. And the tribe has worked with us and kind of has helped choose our placement, but that place is now under construction, which we knew was coming. We didn't know exactly when. I went on vacation and came back and it was kind of under construction. So that has also been one of the reasons for having this a little bit more urgency in this, saying we need a way to be able to continue to serve the Skokomish community. And then we're in Camilchi on Thursdays in partnership with the Squaxin Island tribe. So not on Squaxin Reservation, but on, kind of that tribal land. And we used to have a site adjacent to Shelton. We've never really had a fixed site in the city limits of Shelton.
It used to be out at the park and ride, right?
The park and ride at the 101, the city center Matlock exit. And that was our most highly utilized site for sure. And then when the on-ramp construction happened, we kind of lost that location. So we're not really accessible. So it's hard to find locations where people can be. Making sure that we're fostering good relationships with our communities and our neighbors. I think maybe I'm getting a little ahead of myself. But I just really want to highlight that it's a huge challenge finding, a fixed site location.
What is the group that's out at Community Lifeline right now?
That's the methadone clinic.
Okay.
Yeah.
Yeah, very single purpose.
Yeah.
And are they busy all the time? That's
Well, so their clientele are there every day because of the way the methadone clinic is run. So they, I think they're Monday through Saturday,
6 days a week. And
6 days a week with medication over for 1 day.
But they only serve those that are registered.
Right.
Yeah.
Sorry.
And it's a highly regulated program, so they do have a lot of kind of legal ways of having that. So in this survey, we also asked about model changes, saying what would work for you if we were to change our program around. What would work for you? So of these 43 surveyed participants, 95% said that they would prefer the home service model. This is the one that would work for them, again, because of that transportation issue and mobility issues. The second options were 23% said you can move around more, move our sites around more, which has its own challenges. This population isn't amazing at time management, and having the vehicle moving around it would have to be for shorter times in each location would be a challenge, as well as finding those locations. As I mentioned, it was extremely hard for us to find the 3 or 4 sites that we did in the first place. There's a lot of at-home daycares, schools, although there's no laws around where you can have these sites.
But you're going to get community blowback.
We want to go above and beyond. We don't want community blowback. We do not want to harm our communities.
But it's all the not in my backyard idea.
Right.
Exactly, yeah. And then the other option was having an actual Shelton location. So 12% of folks said that having a Shelton location would be helpful. And with that, I just wanted to also mention that 80% of our encounters, this is just a 10-month data set that I pulled together really quickly, 80% of those encounters do live in Shelton. All right, moving forward.
Is there an area in Shelton that is heavily concentrated more than others?
It's hard because we used to collect zip codes until 10 months ago. And 98584 just covers so much of an area that it was really hard to tell, because that includes people on the Skokomish Reservation, pretty far out. That's why 10 months ago we moved to saying, what town do you live in? So we could be a little bit more specific. And I have some numbers that, if you're interested. And
I just was curious, if you talk about in-home, is there a homeless population that you're treating as well? And is there an area that would benefit them the most, where they wouldn't have to travel as far?
Yes. So one thing that we started last summer, was doing street outreach to the encampments kind of along Highway 3. And we saw a large increase of...
By the yacht club.
A large increase of engagements. And then since that was removed, and with our staffing challenges right now, I don't have enough staff to really focus on all of the things that we're doing. We have a new person coming, but I've been very, stretched very thin, so that was just one of the things I've had to stop. So that is a population that's not getting served right now, who I think would be utilizers. There's really high overdose rates. Right now, there's no real good place to dispose of used syringes in the city of Shelton, which I know is a huge concern. The literature and the research does show that in areas where these programs exist, there's a lot less needle litter on the ground. So I think that moving forward into Shelton would be a great option. We want to do a lot of changes and see how we can really expand. But I know that things around the city of Shelton have been a little exacerbated with some, how do I say this nicely? There have been a lot of maybe, I guess, like community issues around some of the things going on with the unhoused population and substance use, and we just want to be very careful how we're kind of moving forward and how we're doing these things to not really draw too much attention. But I think that is something that we would be interested in looking at and working with the city to see what could happen. But I think, moving forward, we're just doing kind of maybe a phased approach, and this is one way that we thought would help engage the folks of Shelton, but also not have a kind of like focal point that could cause harm to our neighbors. So maybe I'm getting a little ahead, so let's just discuss real quickly about what this proposed service expansion would be. We want to start kind of as a pilot program, 1-year pilot program, incorporate home service in addition to some of the fixed sites that we're doing. So what this would look like would be using a county vehicle, making appointments with folks, and kind of determining what route and just meeting people where they're at, whether that's a home, agreed upon location, etc. And one thing to note is that home service is a very natural part of public health. We have our communicable disease nurses doing this. We have our I always forget. Maternal child health program is regularly going, in the homes. And we do have some, kind of shared clientele there. And since the beginning of our programming, kind of our harm reduction overdose prevention programming in 2017, we've always offered naloxone distribution, overdose prevention education, at people's homes or locations, as well as some extra wound care supplies for folks who have some kind of chronic and severe infections. So this would just allow a broader scope of our services to be offered kind of in that model. We do believe that it would increase our program participation significantly, and it would really engage people who are not currently accessing overdose prevention, as well as behavioral health and social services. One thing to note, at the last stakeholder meeting where we had the folks who were running for election, including our incumbent Randy Netherland, one of the comments that people had made and there was this discussion around how do we access people who are not kind of visibly in public intoxicated or getting engaged with social services. How do we actually get the people who are kind of functioning pretty well and they're in the homes and they're not maybe what we would be an identifiable as somebody who is using drugs. And I think this model would really help fill that gap because we'd be able to maintain privacy. Privacy is also a huge concern. We're a very small community. People are really afraid to be seen at our program.
Or a county vehicle being seen driving up to the house.
Yeah, so we would be, and we'll talk about that, but one of the things we'd be using would be a county vehicle that might not have our logo on it, or we'd be covering the logo. I have talked to a couple folks saying, would this be an issue for you? And that doesn't really seem to be a huge thing, but I think more just having it going, being able to be private would be a huge asset.
So if they had red or blue lights on top, that might be an issue.
Yeah. We would be offering kind of the exact same scope of services that what we're already providing, with the addition of the clinical services, which, we're really still in the planning phase. I'm not sure what that scope will be. Our health officer is in full support of this, but he maintains, because he'll be doing it'll be operating under his medical license and his clinical supervision. So he wants to work with the provider, whoever we hire, to see their level of experience and comfortability and before we really determine what that scope of clinical services will be. So that's, still pending. And as Melissa mentioned, we already have secured funding through the Department of Health's endemic grant, as well as the Foundational Public Health illicit substance funding.
Does that grant have an expiration date or?
The DOH Syndemic Grant, where it's a calendar year, so January to December, we're in year one, and it's expected to be a 5-year funding source. Of course, state grants are always kind of up to whatever happens in the legislation, but it is expected to be a 5-year funding source. And the Foundational Public Health, I don't think has an expiration date. That's just a yearly sum of money.
It's an allocation from the legislature that has been written into law.
Is
So
that
FPHS.
is the amount written into law, or is that?
No,
up to the
that is subject to
legislature?
the legislature's, budgetary thing, so.
Is that on the, sorry, another rabbit hole.
Yeah.
Is that on the priority list for Wasalfo to make sure that that
Yeah,
funding
yeah.
stays in?
So in fact, we're not asking for an increase this year because we understand that the state is looking at some funding issues, so we're not asking for an increase, but the money we have coming in currently will cover what we want to do. So we're in good shape fiscally.
Yeah, we're also writing another grant that is due on Monday. That would also, increase, if we were to receive it, to increase this, and so then we would have some more money to be a little bit more flexible with it.
Okay.
Yeah. So again, I think we touched a little bit about why home service is what the model that we're kind of hoping to pursue right now. Really, we're just trying to reduce barriers to folks who are to access services. That is just plain and simple what we're trying to do. That's our mission in public health of reducing that by meeting people where they're at. And I also just want to kind of highlight that this model has been wildly successful with our local Mason County behavioral health providers and partners. So there are many agencies and many programs that are working with this exact same population who are regularly going to people's homes or meeting them. So we have Olympic Health and Recovery Services who have our law enforcement co-responder programs, and they're working with people with pretty high acuity needs. Our law enforcement assisted diversion program, and they're again regularly, going to people. Our North Mason Regional Fire Authority's Mobile Integrated Health Program has just been a great success and their data really shows that these are folks who were not accessing even very basic medical care, and so this could just really help bolster. As far as funding as well, one of the things that we've always done since the beginning of the program has tried to staff our program with partners from these other agencies. One, because we want to have a peer navigator who can share their lived experience, inspire support, and make that seamless link to services. Right now, we're partnering with, Olympic Health and Recovery Services has been one of our partners. Their grant to help fund, well, now I'm getting too into the weeds, but right now, one day a week, we have somebody from the Law Enforcement Assisted Diversion Program. She also works in the jail with the Medications for Opioid Use Disorder program. So she's there to, again, make those connections and provide case management. I have had and I've started, we started going out once a month with the Mobile Integrated Health Program in North Mason, so we can kind of bolster the services they're providing as well as some of the things that I'm providing and try to increase that success. And we've had some conversations with many of our partners, just very informally about, would you be interested in working with us? I've talked to both tribes. Again, they're waiting for, an official decision to be made before we do anything moving forward. But both Chris Peters, the tribal chairman for Squaxin Island Tribe, seemed really excited about this program, had some couple ideas of programs. And of course, he wants me to talk to some Maine folks first. And Denise LeClaire, who's the director of the health clinic for Skokomish tribe, also was excited and in support, and she just said, when you're ready to move forward, let me know. We'll go to tribal council and see. So I do expect that we would be able to really increase our partnership with tribal members and also partner with some of them. We don't want to duplicate, and this is also a way that we use our funding wisely, is trying to find other programs where the model
In fact,
fits.
tomorrow we're meeting with anybody who's interested in providing or is providing mobile health services. Get together in a powwow and talk about who's doing what, who are they serving. Let's not overlap unnecessarily. There will be overlap, but and figure out where the gaps are. I spent last week in Texas going through training on establishing mobile health clinics. So we're going to do something aligned with this, but bigger, and that'll be coming down the road, literally, before too long.
Because I don't know, but are there private organizations or churches, et cetera, that are going out and providing services like this here?
Some churches do have some things. One of the, maybe not medical services, there's a variety of different things that are happening. One of the things that I have started recently is actually bringing a collaboration meeting together. So we have 2 different meetings that started in, I believe it was June. One is a larger collaboration meeting with all of the face-to-face boots on the ground providers from housing, behavioral health, et cetera. We do have some faith members who are coming there, just so we can get to know each other and really know intimately what services are available, what things, so we can provide more appropriate things and kind of troubleshoot, I have a challenge with this, when I'm working with your agency, this is one of the things that comes up, how can we actually do something about it? So that's been pretty successful so far. And then we've also started a smaller outreach worker only meeting. These are agencies who have actual street outreach workers, so we can start collaborating and work together, both for the partnership. So the capacity, the staffing capacity is kind of shared with our partners, as well as improving equity throughout the county. So this is one of the things that I've kind of noticed working in public health, both as a boots on the ground worker and also looking at the system level work and really having a good idea of what's going on, is I was just noticing that a lot of services were being focused on high population areas, kind of where it was easier to see and find people, but it was not being equitable throughout the county. And so one of the main reasons is that we want to be equitable. We want to ensure that the entirety of our rural community are having access to care. So that's another really main reason. Yeah.
I'm sorry to bother you, but I've got Kevin who's going to be able to pop on for 1 second to do a vote so we can move on with this stuff. Because I think this is really important. I'd like to see us move on. I need a phone number to send him. Can access the Zoom link.
Yes.
If you don't mind, we'll break quickly when the time comes and have a vote so we can have an official meeting.
Yes, I can track down that phone number.
Thank you. Go ahead and continue, Christina, but again, if he gets on, if you don't mind, we'll take a quick vote. And
I would not mind.
Go
Thank you.
ahead.
Thanks for facilitating that. And the last point I just wanted to talk about again is that we know that this program has, can be a little controversial. And again, having this kind of home service model would allow for increased equity, increased service expansion, again, without kind of creating a focal point for that could disrupt neighborhoods. Safety considerations, we understand that this is one of the main concerns, rightfully so. Oh, really quick, just backing up, I also wanted to say, as far as this model being successful, I just want to say that we are not the first program who's trying to do this. The Kitsap County program has operated under this model for decades or years, if not decades, and the Tacoma Pierce County program also does this. And I have shadowed both of them. I have learned what they've done. And I've also, in my old program, because I ran a similar program in California in I think 2008, and I did this as part of my programming there. So this is a pretty common model, especially for rural areas. Okay, moving on. So safety considerations, one of the things just to get it off everybody's chest is that staffing minimums will always be at least 2 individuals. If we cannot meet that minimum because somebody is sick or out or whatever and we can't find appropriate coverage, that service will be canceled for the day. We will absolutely not be, anyone will never be going out alone for this particular model. We have a lot of other additional safety requirements in our home service policies and procedures. So first of all, public health already has a general home and field service policies and procedures that was developed in partnership with risk management, again, because a lot of our staff are already doing this type of thing. So when we're looking at our mobile outreach home service policies and procedures, it includes everything in the general home and field service policies and procedures with a lot of additional safety concerns or measurements to address the concerns that folks have. I did send everyone out. I want to say that we spent a lot of time. First of all, before developing this, I talked to a lot of our partners who are doing this type of work. So I worked with Olympic Health and Recovery Services leadership, who do, again, the crisis team. They have the DCR, they have the co-responder program, to see what was in their policies and procedures and training requirements. I've worked with a lot of other agencies that are doing this exact type of work. I've also worked with the manager for the HOST program, and I can never remember the acronym, but this is the Healthcare Authority program that has a team that go into encampments. So they're really the team going deep into the encampments to connect people with services, with behavioral health challenges, substance use disorder challenges. And so I did work with the manager who runs that entire statewide program to see if they had anything else to add. So we spent a lot of time, again, doing our research before coming up. We had a draft, and then we went to Nicole Wilston and to Tim Whitehead. Well, Nicole and I actually workshopped these for a couple hours together, just to ensure that everything was in alignment with county policies and their risk management. Risk pool, signed off on that. And then we met with Tim and went through everything else. So they have signed off on it. They think it looks great. And we do have a lot of training requirements. Of course, we can never ensure. Yeah.
Sorry to bother you, but Kevin could not get through. The other way, we have him on the phone right now with me here. So if you don't mind, we can go ahead and do a motion so that he can move forward and continue and not get any crashes.
Mr.
He's
Chair,
on the road.
Mr. Chair, I move that I move to approve the agenda as presented.
I'll second that.
There's a motion and a second to approve the agenda as presented. All in favor say aye.
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 Aye. The motion carries. Is there a motion to move this forward to the commission?
I so move.
I'll second.
Okay, Peggy Van Buskirk moved to move this this program forward to the commission with support from the Board of Health. Any comments? All in favor signify by saying aye.
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 Any opposed? The motion carries. I'm gonna go ahead and let Kevin go unless anybody has any other issues they're gonna need. If so, say so now. Excellent, Kevin, you rock. Thank you. You just saved the meeting. Have a great one. Be safe.
Felt like,
Okay, guys, you're good. Sorry.
felt like you were a preacher there for a minute, Randy, saying, "Speak now or forever hold your peace."
Sorry about that. And normally I would be there. Some reason there was a glitch in the matrix. I was actually on my phone. I'm one of those guys, I panic. I look at my meetings 20 times a day because I'm afraid I'm gonna miss one. While I was watching, it actually popped up while I was looking. I'm like, what the heck? So it was stuck in the matrix. So my apologies, or I'd have been there. Okay, go ahead and continue, and then we can finish up.
Great. So in addition, one of the things that, for safety training, which I think, you might even be especially interested in, there is a Murray Smith training. This is I think I took the notes out, but this is a required training. There was an RCW developed in, I think it was 2008, but don't quote me on that year, that requires mental health professionals working in behavioral health agencies who are meeting people in clients' homes to do this training. It's called, and so DBHR has developed the Marty Smith training that has a lot of models. I've actually taken this before in a different position that I had before, so that will be an annual requirement, as well as a couple of extra things. I wrote on these, this is kind of our draft policies and procedures because we're still working on some things. Situational awareness and de-escalation, understanding that we can never, if something happens anywhere in the world, we can't necessarily prevent that incident from happening, but we can prevent additional harms from us. So just knowing what's going on, and we're good at that already, but Tim wanted us to work with the sheriff's office to determine other trainings and to have them do our training. And so Sheriff Sperling has agreed that he would be happy to provide that for us. So we'll do annual training. We have some information on how we'll ensure that's getting done. It'll be actually through the Munis system, so it'll be worked with management to ensure that we've done it, and then that record will be kept with, I think HR keeps those. Is that true? We have a lot of other things. One of the things that we were working on is GPS tracking. We have some conversation around HIPAA compliance, unions, etc. That's why this is still in draft form. We have some work to do around that. And as far as determining, where we are, and so we did go above and beyond what I would say anyone else that I've talked to have done, in order to ensure that we're as safe as possible. So in addition to having some type of GPS and hopefully with an emergency alert button, that would be best case scenario is on person, we'd have an emergency alert in case something unexpected happened. But we'll also be using probably using our Outlook calendar. We can workshop this if there's other apps or something that work. But basically, once we have the scheduled route, so participants will call the day of, between 8:30 and I'd say 11. Tell us exactly who they are, where they are. We get their name, contact information, location, etc. We put that in a system to create a route that makes sense. And then in Outlook, which is accessible by all of our leadership, we would put all in one color. So let's say blue, everybody's the expected route, the expected time of arrival with their name and contact information. And then once we have left that location safely, so not after we're done talking, I'm still sitting there, but after we've left, I will change the color of that appointment to green. And that way anybody can look into my calendar and say, okay, this is where the team is, and this is where they're still expected to be. So we have a couple other things, but that is the best one that I was able to come up with for something like that. Very open to suggestions. Next steps, we do need to finalize our pending items. We need to continue to work with risk management on, some of the items that we mentioned. Again, we wanted to get, the blessing of the board, so I think it sounds like that has happened. So we will now proceed with briefing the Board of County Commissioners, which is on the 23rd, not 24th. Once this is approved, we will approach, tribes and other partnerships to see if we can partner officially, which we'll be making MOUs and, we have all of that other stuff detailed in the policies and procedures. We already have the approval of the purchase or lease of a vehicle for this, and implementation can really start as soon as the staff can be completely trained and all of these safety measures are attained. And so that is the end of what I got for everyone. Any questions?
Anybody have any questions?
I do have a couple, but they can be discussed during commissioner briefings, because what I want to do is make sure that the job description matches the job performance.
Mm-hmm.
And then some of the others I'll talk with you guys later.
Okay.
All right, anybody else have any questions? Yeah, I want to clarify something for Commissioner Schutte. He did not go into this blindly, and he did not vote blindly. I want you to know that he was fully briefed. He had the program in front of him as well. So it was not just a willy-nilly thing. So when we contacted him to come on for a vote, he was completely up to date on everything before being asked to vote on this.
Yeah,
I just wanted to clarify for the record for everybody, and very much appreciate him pulling over the side of the road to make it happen.
I also want to make sure that everyone knows that you guys came and you spoke with the commissioners also, just to get any concerns addressed or anything else. So I want to thank you for doing that.
Yeah. We really wanted to set ourselves up for success. We knew that there were going to be maybe some strong concerns specifically around safety, which I do appreciate a lot. I also have a lot of, concerns around safety and wanted to ensure that we did set ourselves up for success. So, and I have, again, we've talked to all the partners and I have I think we will probably be able to partner with some really amazing programs to do this. So that will all be coming soon.
That's one of the biggest things I'm supportive of, is finding different modalities to bring into this so that we can spread out the idea of going into a home. There's got to be a lot of ways we can touch, a lot of more benefits that will come just by doing this. Look at what they've done up in North Mason with just basic medical. I can see how easy this is going to be extremely successful in this realm.
Yeah.
Right. Any further questions or comments? Then I'm going to go ahead and move on to are there any board member comments or discussions for old business? Any board member just discussions in general?
Nope.
Hearing none, I don't really see much in the way of public, but a person could be, so we'll go ahead and ask if there's anybody in the public who would like to create public testimony at this time. Please unmute yourself, say your name, and we'll call on you. Anybody would like to, we just lost one, no, that was Christina. Anybody like to do a public comment? Hearing none, if there's no objection, I'm gonna go ahead and adjourn the meeting because we no longer have a quorum anyway.
Great.
All right, hearing no objection, we are adjourned. Thank you, everybody, for coming in.
Yeah, thank you.
So you talked about some of the issues